Thank you very much. It's an honor to be here, and especially to follow Dr. Chan in the keynote. I'm not a neuroimmunologist. I did go to medical school. I did take neuroanatomy. As I recall, I took it twice. I'm here to give you an overview of autism. And I think from your specialty point of view, it may seem somewhat general. One of the strategies that we pursued at the Autism Research Institute of San Diego is to try to recruit scientists from the basic fields of science outside autism. And we've had a significant success in doing that. And we'd like to expand on that success by this venture into the neuroimmunology field. I might ask, in the audience, are there any neuroimmunotoxicologists? No neuroimmunotoxicologists. But you are neuroimmunologists. And are there any of you doing research germane to autism at this time? Show of hands, we got one. Are there any of you even obliquely interested in autism? Yes. Do any of you have family members or friends with the condition? It's a spectrum of behavioral disorders. There's the autism spectrum disorders number 3. They are called ASD, Autism Spectrum Disorder. There's considerable variation in the behavioral presentation of these diagnostic subcategories, with significant variation among individuals. It's important, I think, for you to understand that from the outset that autism, in general terms, divides between early and regressive forms. The early form of autism being discernible in the early stages of infancy often, certainly before the age of 1, and trouble from the start. Maybe an early sign of autism might be poor eye contact, or poor maternal attachment. The regressive form of autism was denied by the field for virtually decades. But it is, if anything, now probably the more dominant form. These are children who are mostly okay behaviorally for the first 12 to 18 months and who largely meet developmental milestones and then lose function, and sometimes within days or weeks, and often very dramatically. And for the parents who see this happen to their children, a real tragedy, akin to losing a child. It's not a pure distinction in that they've gone back and looked at the first birthday videotapes and found that there can be subtle differences in eye contact in the children who later developed the regressive form. But the dichotomy works in our understanding of autism to think of both these forms, and it would appear that the regressive form is on the increase. It's a strictly behavioral diagnosis. We don't have a laboratory parameter or a picture of autism. We can't scan for autism. It is strictly based throughout its history, which goes back to its original description in the early 1940s, on a behavioral basis. There have been some evolving concepts as you study the evolution of the field. The first descriptions of autism in the early 40s were followed by references in the journals and in the textbooks well into the 1960s as a psychological phenomenon. Freudian. The field for over 25 years viewed it primarily as the result of cold and uncaring mothering and a psychological reaction of the infant. That's given way to the biological model. There's also a static versus dynamic consideration. Because autism, perhaps at an early stage, was considered probably a result of disordered architecture. But now is conceived of as a dynamic process involving inflammation and fluctuations. A good review of that is provided by Harvard's Martha Herbert. And what I've done through all of my slides here, tried to do is I'm giving these numbers, as you see here under static versus dynamic, for the PubMed reference number, if this is of use to you. Genetic versus environmental considerations. While most of the funding for autism research has gone into the genetic inquiry, certainly that, and that certainly revealed over 50 polymorphisms which associate with an increase in risk of autism. None of these polymorphisms are enough to account for all of the cases. We knew this would be the case, I think, just based on the concordance figures in identical twins, which in studies, in multiple studies of twin studies in autism, and the concordance for autism in identical twins ranges between 20 and 80%, and the best number is probably something like 50 or 60% of the time. One identical twin will have the diagnosis and the other will not eventuate the diagnosis. And then a newer concept, which we've been formulating at the Autism Research Institute, would view autism not strictly as a behavioral disorder, but as a somatobehavioral syndrome, which combines visceral findings as an inherent part of the disorder. Bernard Rimland was one of my primary mentors in this field. He, back in the 1950s, diagnosed his own son's autism at a time when most practitioners had never seen a case of it. And this was his fourth child by the same spouse. And he stood up to the field of science and said, no, this isn't Freudian. This doesn't have to do with cold mothering. My wife used the same love and care for all of our children. This must be biological. Bernard Rimland, more than any other individual, helped free autism conceptually from Freud. In general terms, we know about the morphology of the brain in ASD. It's larger than controls in the younger population for the first few years of life. And then this size difference declines over time. There is an increase initially in white matter, but a decrease in functional connectivity of various brain parts. And neuroinflammation is a dominant theme. We have a review article here which would be a useful reference. There aren't a lot of brain studies in autism. The brain banks have very few specimens. Much of the frozen tissue on hand was lost 2 or 3 years ago by a freezer failure at Harvard University. We're really on trouble in terms of collections and storage of brain. But what we do have is several core articles, which I will summarize here. There's increased number of microglia and numbers and activity in the cortex described in the first study in 9 of 13 subjects, including 2 of 3 who were less than 5 years of age. There was an increase in density of microglia in the gray matter and total volume of microglia in white. Microglial activity on PET scans of ASD in the adult population aged 18 to 31 was increased through a wide range of brain areas for midbrain, pons, fusiform, cortex, cerebellum, and cortex. The cytokine profile in ASD reveals increased MCP1, TGF beta 1 in cortex, white matter, and cerebellum. This was a Johns Hopkins study. There's a significant increase in the TNF-alpha, interleukin-6, interferon gamma, IL-8, and a shift to Th1 in a study of, I think the cohort was 11 or 12 brains, by the New York State Institute for Basic Research in Staten Island. This is reflected in the graphically in IL-6 on the left, TNF alpha, IL-1 beta, and GM-CSF in pink for autism and versus gray for control in this graph. The peripheral cytokine profile has an increase in plasma TNF alpha and interleukin-6 in the younger ASD. This finding was mostly due to an increase in these inflammatory cytokines in the regressed subgroup of the cohort. The increase had very strong associations with the degree of behavioral impairment. In a second study, the peripheral blood mononuclear cells had increased Th1 with IL-2 and IL-1 measurements, but an even greater increase in the Th2 cytokines, but no compensatory shift in IL-10. The peripheral phenotype is highly oxidative, very, very high oxidative stress. One of the outsiders to the field of autism that we successfully recruited into our research pursuits was George Perry, who was very, very important in identifying the contribution of oxidative stress in the pathogenesis of Alzheimer's disease. I'll be showing his carboxyethylperol findings in a moment. But the peripheral phenotype has a doubling of nitric oxide in plasma and cells and xanthine oxidase. Less protective antioxidant function reflected in lower glutathione and glutathione peroxidase levels, catalase, ceruloplasmin, and transferrin, and then just more oxidized biomolecules with double the lipid peroxides and isoprostanes. Domenico Pratico from the University of Pennsylvania published one of our studies, which also, besides the elevated isoprostane, showed an isolevuglandin associated with endothelial activation and platelet activation. Bruce Ames, right here from Berkeley, took an interest in our proposals and measured in a really very, very careful study, measured reduced glutathione levels in plasma and also the peripheral blood mononuclear cells, and found a significant decrease in the levels of glutathione intracellularly, as reflected here with a P of 0.0004. Brain, as we all understand, is highly sensitive to oxidative stress, and due to its high oxygen consumption and the oxidizable catecholamines, the fragile blood-brain barrier, modest catalase and reduced glutathione levels, high glutamate, iron, and fat. And in autism, we have few studies, but the studies we do have reflect a rather generalized oxidative insult. Increased lipofuscin associated neuronal cell loss was identified by an investigator from Spain, and I'll deal with that in a moment. Increased axonal carboxyethylperol, the Case Western lab did this one, and the increased isolevuglandin and heme oxygenase in brain. And then a Harvard investigator, Elizabeth Sajal-Silkowska, published increased nitrotyrosine levels in the cerebellum and cortex with correlation of these levels with mercury. Lipofuscin, as you well know, is an oxidized lipid and cross-linked protein, and it serves as a depot for heavy metals. It's classically associated with neurodegeneration and inverse activity to brain activity, and of course its secretion is slowed by supplemental vitamin E. Edith Elizabeth Hurtado from this university in Hernandez in Spain presented a study which showed an increase or a progressive decrease with age in neurons and increasing glial cells in specific layers with progressive increase in lipofuscin throughout cell layers of 3 cortical areas in autism. And these graphs reflect those lipofuscin cell counts. You know, it was probably a rookie mistake, but we put this in a journal which told us that which dedicated a whole issue to autism. We sunk Bruce Ames and George Perry's splendid articles into this, and it's called the American Journal of Biochemistry and Biotechnology. This is not a negative comment on that journal at all, but we really had been assured that they were going to get Medlined, and they didn't. And it's a shame that this data has kind of dropped out of circulation, gone relatively unnoticed. I've given the reference for it, and it can be called up online here. It's American Journal of Biochemistry, Biotechnology 42208, or 2008. Not Medlined, but we're pretty proud of the data in there. This is, on the left, the carboxyethylperol. This is a stable oxidative metabolite and, of DHA. And on the left, showing up is the darker pattern, which is almost exclusively axonal in its distribution, compared to the paucity or absolute lack of it over on the right control. We found this in multiple brain areas in autism. Our Harvard study found the increased cerebellar nitrotyrosine, 3-NT, and a strong association of it with the mercury levels in the cerebellum. One of the questions, of course, if you're having neuronal loss, activated microglia, inflammatory cytokines, oxidative modification, and loss of function, I mean, regression is loss of function. They quit talking. They quit socializing. I mean, they've already got 25 words and they just clam up. It's a loss of function. And then the progressive increase in lipofuscin over 3 decades. Is this a neurodegenerative process? Is a question we ask ourselves. Is there a significant excitotoxic component in ASD neuropathology? Hami Atamna of the University of Minnesota 20 years ago published lower glutamic acid decarboxylase levels, 50% lower in the ASD cortex. The GAD mRNA is lower by 40% in the Purkinje cells of the cerebellum, which have been consistently one of the more prominent changes in autism brain studies. There are, in fact, increased glutamate levels in plasma, and of course, excitotoxicity being aggravated significantly or potentiated by lower energy production. The decreased ATP measured directly in the cortex of ASD or indirectly on MRI studies is of interest. There's also a significant question of systemic autoimmunity in autism. The IgG4 in plasma is significantly elevated. The anti-nuclear antibody is seropositive in 20%, which is about 10 times the control incidence. And antibody to nucleosomes experimentally is found in half of the ASD. Antibody to endothelium is found in a smaller cohort, or a subgroup in the cohort. Brain-binding antibodies are found in the limited number of autism studies relevant. Increased antibody to myelin basic protein found in 75%. Antibody binds to brain nuclei in 27% of the ASD, 45% of the LKS, that's the Landau-Kleffner syndrome, which looks just like autism by diagnostic criteria, but falls a little later chronologically, older than 3 years of age, I believe, is the current criterion. And only 2% of controls have the antibody specific binding for brain nuclei. And then antibodies found to bind only the GABAergic, Golgi, in 21% of the ASD brain. Now, IgG from ASD subjects binds control brain extracts 37% of the subjects versus 13% of controls. The binding was especially prominent of all brain areas sampled in hypothalamus. Lower areas of brainstem, don't get too much consideration in autism yet. And part of the purpose of my presentations today is to change that. When I read this some years ago, I was looking at this and I thought, well, isn't there an area in the upper brainstem, in the hypothalamic area, the median eminence, which might be a factor here? I remembered rather vaguely that the median eminence was one of just a few select areas of brain which never develop mature blood-brain barrier with tight junctions. They remain, in the normal case, permanently open and absent of the tight blood-brain barrier. And I started thinking about this collection of so-called circumventricular organs, which are listed here. The subfornical organ above, organ vasculosum, median eminence, the posterior pituitary, pineal, and area postrema. A little later, in the second talk, I'll be giving you an idea about some laboratory and clinical abnormalities which would seem to correspond to the specific functions of a couple of these CVO. The median eminence and the area postrema, besides lacking blood-brain barrier, lack brain CSF barrier. They don't have tight junctions with the CSF. That might be important when we consider the very, very high levels of inflammatory cytokines in the cerebral spinal fluid in autism. Microglia and toxins. Well, we do know that the microglia in response to toxins, and since none of you are neuroimmunotoxicologists, I guess I can get away with murder here. The toxins are known to stimulate the release of cytokines and antioxidants from the microglia and associate with the neuronal loss. And certain toxins, and I'll be discussing how the toxins that we're really very suspicious of in autism, and we name, are known to be highly stimulatory of the microglia and also concentrate in the CVO. Cadmium is in the hepatic inflammatory response to cadmium, for instance, is so enhanced, so great that it's one article referred to cadmium as the inflammatory toxicant. But I'm getting ahead of myself a bit. The thought that we're testing at the Autism Research Institute is that visceral dysfunction that we see in the children with autism and adults with autism may be an inherent part of autism and reflect the basic pathogenesis in the brain. And I've sketched the immunologic findings, which suggest dysfunction of the immune viscera. Those cells are viscera under, largely under autonomic control. But the other areas of visceral dysfunction where there's pronounced abnormality in autism are gastrointestinal, cardiovascular, and laryngeal function. When I first started seeing autistic children 20-odd years ago, I had two distinct gut feelings about my interactions with them. My first was, these kids cognitively are processing at a much higher level than their communication skills allow, that reflect. Right away, I was noticing that a child with ASD might respond very appropriately to a question about an object by pointing to it where he could not say anything about it vocally. So, smarter than they're talking. And the second really profound clinical finding in autism for me, seeing virtually hundreds of these kids was, boy, their guts really are dysfunctional. These kids, 100% of them would, I think, be constipated if they did not have such, in some cases, profound microbial overgrowths and malabsorptive syndromes. But I'll show you more about that. Many of these children, nonverbal, will press against blunt objects, press their abdomen against blunt objects, doorknobs or the corner of a table for presumably discomfort, to signal discomfort. My own son, just every night I would have to rub his stomach to get him to go to sleep. They have a lot of pain, a lot of constipation. And these are the 4 areas: immunologic, gastrointestinal, cardiovascular, and laryngeal, which are visceral. And we're testing the idea that these visceral changes may reflect something really important to the behavioral and somatic phenotypic presentation. That's reviewed in the article cited by PubMed. Now, some of the work that's been done here was stimulated by parent observations. This Autism Research Institute, which Bernard Rimland founded, funneled a lot of useful feedback from a parent group. Bernie's gone now, but he left behind a 200-item questionnaire, which has generated 35,000 responses from parents, which are not the tightest level of scientific evidence, but they're a good guide, we think. But the scientific evidence, the gastrointestinal dysfunction in autism was actually signaled to the field of science by parents making the observation. Carolee Horvath, who at the time was from the University of Maryland, in 1999 published the first article, first really credible article, I think, on abnormal gastrointestinal function in autism in the Journal of Pediatrics. And he did endoscopy on the kids, and he found esophagitis and really dramatic inflammation of the esophagus from esophageal reflux in a full 2/3 of the cohort. And then the Paneth cells on microscopic examination of the duodenum, the duodenal biopsies. The Paneth cells are the secretory cells which make defensins. These are provide broad protection from in the antimicrobial defense against viruses, yeast, and bacteria. The Paneth cells are, and I'll show you a slide in a moment, are full of unreleased granulations. One published study showed in a strictly regressed cohort, as opposed to the regress plus early onset, showed radiographic constipation, including megacolon in several of the children, in 100% of the group. The children will often come in with parent complaining about painful diarrhea, sometimes even bloody diarrhea. But what they're really having is an overflow diarrhea around significant colonic impaction. And the thing that really is, I think, the clincher here, that this is part of autism and not epiphenomenal, perhaps, is that we have published reports here in 2 cases that the gastrointestinal problems appear to start coincidentally at the same time as the behavioral changes when there is a regression. Here are the Paneth cells from Carolee Horvath's study from 1999. The dark staining granulations in the left are from the ASD child versus the ones on the right. He was doing a secretin infusion test, which measures the amount of the pancreatic response to intravenous secretin. And he found that this was an overly robust release of pancreatic enzymes as well.